going? Good morning or good afternoon, depending on where you're joining us from today. First off, thank you all for spending your Saturday with us and attending our quarterly vision webinar. My name is Bailey Bostleman, and I'm the Regional Field Director at the Foundation. We are so excited to be with you today, and thank you for sharing your Saturday with us. I would like to briefly review some logistical details for the call. Currently, all participant lines are muted. Today's call is being recorded and will be shared with all registrants after the meeting concludes. You will also be able to find the recording on the Foundation Fighting Blindness website within the coming days. If you are using a screen reader, please be aware the controls are at the bottom of the Zoom interface. This control bar may collapse when not in use, so make sure to joggle your mouse before clicking anything. If you prefer to prevent the controls from auto-hiding, go to your settings within the Zoom platform, select Accessibility, and then select Always Show Meeting Controls. If you have any questions throughout the presentation, please send them using the Q&A function within the Zoom platform. We also want to send a big thank you to our national partners who help make educational events like this happen. With our TED partners and our Gold and Silver Outreach partners, they help bring these webinars to your home once a quarter. So huge thank you to all of them. So today our experts will discuss various topics related to thyroid eye disease, which is otherwise known as TED or TED. The Foundation Fighting Blindness is committed to supporting the TED community through educational, networking, and awareness building activities. In partnerships with organizations focused on TED, we provide educational resources and host community events such as webinars that connect TED patients and their families with each other and the broader ophthalmic disease community. At the end of the presentations, we will open the floor for Q&A from our panelists. Whether you're a patient, caregiver, or healthcare professional, we hope this webinar offers invaluable insights. Now I'm pleased to hand it over to our moderator for today's discussion, Ben Shaverman. Ben Shaverman is the Vice President of Science Communications at the Foundation Fighting Blindness. You may recognize him from the Eye on the Cure podcast or his many presentations where he shares the latest scientific advancements in the community. Ben has dedicated his time to helping those in the low vision community to understand their retinal disease and the research underway that may benefit them. Thank you, Ben, so much for joining us and leading this great conversation today on TED. Oh, Ben, I believe you're muted. Sorry about that. I think it auto-muted everyone.
Thanks, Bailey. And thank you to everyone out there who's attending the webinar. It's a pleasure and a privilege to have you with us. As Bailey said, we're going to learn all about thyroid eye disease, what it is, how it's diagnosed, some management strategies. I think we're going to get into treatments and maybe some research. And I'm excited to get an overview from a couple of great doctors, and then we'll learn about the patient journeys as well from a couple of people who are affected. And the basic flow of the program is we'll hear from the doctors first for a little bit. We'll kind of start delving into TED. Then we'll hear about the patient journeys. Then I have some questions that I'll ask everybody, mainly the doctors. And then if you have questions out there in the audience, you can type those into the chat. And the latter part of the webinar, we'll get into the questions. So I'm going to start off introducing our presenters, our panelists. And one thing I wanted to add, which I think is an important thing to say, in the back and forth and some of the communication with the doctors, they had a key message for today's webinar, and that is, quote, "You're not alone. Support and new treatments are available." So I think that's an important point, an important theme to kick off this webinar. But first, I'm going to introduce everybody. The first doctor we'll hear from is Sonali Kachikian. She's an MD and a board-certified endocrinologist. She completed her residency and fellowship in Albany, New York. She now resides in the Black Hills of South Dakota and has been practicing endocrinology for the last 16 years. She covers a wide range of endocrinology disorders, but over the last few years, she's had a special interest in thyroid and thyroid eye diseases. And she strives for excellence in her practice and continues to educate patients and anyone interested in thyroid eye disease. So welcome, Dr. Kachikian. Next, we'll hear from Dr. Maya Kostic. She's an MD, PhD, and a specialist in neuro-ophthalmology and pediatric ophthalmology at Bascom Palmer at the University of Miami, where she serves as assistant professor of clinical ophthalmology. She completed her medical training and doctorate in Serbia before pursuing advanced research and clinical fellowships at Bascom Palmer. Her work focuses on preventing blindness across all age groups with active research in thyroid eye diseases, inherited retinal diseases, rare genetic disorders, and multidisciplinary care for complex neuro-ophthalmic conditions. So great to have you, Dr. Kostic. Thank you for joining us. And then after we hear from the doctors, again, we'll hear from two patients. One is Julie Owens. She is a 30-year educator, certified professional development trainer, advocate, and consultant. After dedicating years of tireless advocacy for public school education, she has transitioned her passion to a broader audience, focusing on health-related challenges. Her experience with numerous health challenges, disappointments, and setbacks prepared her to do what she does best, advocate. And Julie has Graves' disease. So thank you, Julie, for joining us. We look forward to hearing your story. And last, but by no means least, is David Brent, who was a board chair for the Foundation Fighting Blindness for 8 years before handing over the reins in 2024. And David and his wife, Betsy, got involved with the foundation, I think about 25 years ago, when their son, Alan, was born with a pretty significant retinal condition called Leber congenital amaurosis. And David is also co-founder and principal at Brinshore Enterprises, a real estate company that leverages public and private resources for the development of affordable housing. And David, interestingly enough, was recently diagnosed with Graves' disease, and that's what brings him here today. So let me again share my screen and bring up the first slide and invite Dr. Kachikian to get us started and telling us a little bit about her practice as an endocrinologist and how often and what's kind of her role in helping TED patients.
Thank you so much for having me. I really appreciate it. I think you're exactly right. I mean, the reason we're coming on today is to see if we can educate people about thyroid eye disease. So you may wonder, well, gosh, endocrinologist, why is an endocrinologist here? an endocrinologist is here because Graves' disease is an autoimmune, meaning your body attacks your gland, usually your thyroid gland, and causes you to have an overactive thyroid. It can also, antibodies can also attack your thyroid and make it underactive, but typically with thyroid eye disease, it's because of Graves' disease, which is an overactive condition. So I see a lot of patients with Graves' disease. It's the most common cause of having an overactive thyroid, where you can feel jittery, anxious, have an increased heart rate, lose weight, which not many people complain about. But I was always taught in training that as many as 1 in 2 people who have Graves' disease, which affects your thyroid, can have signs and symptoms of thyroid eye disease. Thyroid eye disease used to be called Graves' ophthalmopathy, Graves' eye disease, and now the correct name is thyroid eye disease. And it can cause a multitude of symptoms. And I'll tell you, when I have a patient who I need to see, sometimes before I even walk in the room, I know what the diagnosis is because the eye disease is pathognomonic for Graves' disease. It can cause a multitude of symptoms. And the reason I've gotten so interested in it is because it's not just a matter of what the appearance is like, it is a debilitating disease. And like any other autoimmune disease, it's a progressive disease, which at the worst can cause blindness. Symptoms that patients complain about, and I'll touch on this just a little bit, and I think Dr. Kosick, my partner, will be able to talk about it more, but patients will often say, my eyes feel like they're bulging out. One time a patient said to me, when I cough, I feel like my eyeball pops out and I can just push it back in. Some people will have really, really mild symptoms and just say their eyes feel gritty or there's a sand feeling. Recently, I'm really surprised that a lot of my patients have double vision, but I'm going to touch on that. And so that's kind of how I got interested. It's not a new disease. It's been around for a long time, but we're living in a very exciting time where all of a sudden there's so much more interest in it and there's so much more coming out. So part of getting patients to treatment is to educate them that this is something that they're experiencing and to advocate for them and then have them advocate for themselves.
Thanks for that great overview and what you do in your practice. I do have a question about the patient journey, and we'll hear more about a couple of patient journeys in a little bit. But at what point in the patient journey do people end up in your clinic? Are you one of the first medical professionals people see? I'm just curious.
Really good question. I think we're in an area of medicine where everyone is lab happy. So if you check labs and your thyroid function is abnormal, then it sets off a red flag. And then sure, they make their way down to me. And if they make their way down to me, that's great. Sometimes they'll have abnormal thyroid function and their primary care doctor will take care of them. But usually when a patient has an overactive thyroid, they will come to me. So I'd like to think that I am at the stage where people see me pretty early on. But a lot of patients, it's really interesting. Like I was recently in the hospital seeing a patient who came in with an irregular heart rate that was very fast. And they checked their thyroid labs, and their thyroid labs were abnormal. And I said to the patient, I said, do you feel like your heart ever goes fast? He's like, sometimes, but I just thought I'm, easily winded. What I'm saying is, or another patient said, yeah, but I feel like I'm menopausal. Sometimes these symptoms start off very slowly and patients don't always see a doctor. So sometimes, yes, I'm at the forefront of people who see me when they have an overactive thyroid, but it starts so slowly that it may take patients a long time to get there.
Right, right. And does Graves' disease and or TED, are they progressive or do they kind of ebb and flow depending on maybe factors we don't quite understand?
So I think the answer to your question is yes. It is a progressive disease. So when you have an autoimmune disease, it's really hard to know what sets your immune system off. Stress can set it off. We know that in patients with thyroid eye disease, smoking can make thyroid eye disease much worse. older patients or women, which you can't control, have worse symptoms than others. We know that one of the treatments for Graves' disease, which is the overactive thyroid, iodine can make symptoms of thyroid eye disease much worse. So there are factors, but like any other autoimmune disease, it kind of has this ebb and flow where for whatever reason your immune system acts up and then you go into a period of quiescence where it's quiet. And then I always tell people it's nothing that you've done besides those factors we talk about. Any kind of perceived stress, even pregnancy, can exacerbate symptoms.
Okay. Good to know. Good to know. Thank you again for that introduction and the perspective from the endocrinologist. So let's hear from Dr. Kostick. Dr. Kostick, tell us about perhaps when people arrive in your clinic and how thyroid eye disease affects the eyes.
Yeah, thank you, Ben. Before I start explaining eye changes, I just really would like to thank you for organizing this such excellent meeting. And I'm very honored to be part of this meeting. And I think that we need more and more those meetings where we can work together as a group, as a multidisciplinary group. And I think this is really need to have all of us together, endocrinologists, ophthalmologists, our patients, then all other, groups that are around patients, around thyroid eye diseases. So when we are looking for the patient that has thyroid eye disease, because my primary clinic activities are in neuro-ophthalmology area, even if I'm doing like many other things, but patients are usually coming in my clinic either because of double vision or eye pain or vision loss. So those are three most often symptoms that patients are coming in my clinic. And now more and more patients are coming with already some, either Graves' disease in the way how we are collaborating with our teams, with optometrists and others. So, but when we are looking into eyes, here is like, we didn't want to put like many slides, but I think that one picture is telling more than 1,000 words. So here we can see this girl or young woman that has, changes in her eyes. And then when what Dr. Kachikian said, when you open the door, you understand what is the disease here. And then for TED, for thyroid eye disease, it's not disease of neuro-ophthalmologist or oculoplastic surgeon or dry eye specialist. It is really the disease that is affecting each part of the eyes and whole visual pathway. So if we are starting with our eyes from the front to the back, we have so many changes, or we can have so many changes depending of the activities of the disease, depending of the how long patient has disease. There is also different shape of the face or eyes can have also different expression, and sometimes we can be even confused, so if it is because we know either ethnicity difference in our physiognomy. So all of those are different parts. So how I'm like approaching, how I'm like looking into patient that is suspect for thyroid eye disease. First, if you're going from the front, patient is coming with the symptoms like my eyes are always feeling dry, there is greedy, eyes are red, we can see that. They cannot even very often close fully eyes, so, and all of that is giving us very dry eyes that can give pain and blurry vision. So from there, we can have a lot of mucus also. We can have like even more pain. And then we are coming into circle of all of that. After that, if we are looking further in the eye, we can have, I will just first talk about eye and then about all other parts around the eye, including muscles. So in the back of the eye is our optic nerve. So we can have compression of optic nerve, and that is one urgent situation, that is potential blind situation. Thankfully, we don't have many of those patients, but we need all to recognize that or to have suspicious and to urgently transfer patient and then decide about the best urgent treatment. When we are talking about muscles, you can see on those two pictures, the healthy eye on the right side, right up, you see how those muscles are nice, thin, and there is a lot of space between this horizontal line that is going in the back of the eye, we are calling that optic nerve, and muscles. And then if you are looking the lower picture, there is those thick muscles. And then the space that is between this horizontal line, which is optic nerve, which is actually our only connection between eyeball and a brain, then we have, high suspicious for blindness in this type of patient. And we really need to understand this and to treat. And then we have, all other changes in the face, that are coming with proptosis, with all other changes of the eyes, of the shapes of the, different parts of the eyes, including sclera. And more than just eye changes and orbital changes and potential vision changes, we have such a huge impact of everyday life in our patients. And I think that about that part, our patients actually can talk the best because, I have like so many patients when we are doing all of those measurements and everything, when I'm asking them, okay, when was last, how do you feel? And then they either start crying or they are finally they are like, okay, finally I found a doctor that understands all my symptoms, that put like all of those symptoms together, because now we are used to send patients to more and more subspecialists, and usually those patients are going around and seeing many subspecialists, but rarely they are getting like a final diagnosis.
Thanks for that great overview of how TED affects the eyes. A couple of questions, and I'll ask both doctors these questions. Does TED run in families? Do you think there's a genetic component, or is it sort of idiopathic, which is the fancy word for we're not sure why it occurs?
And I can start with that. It definitely has a genetic component. Autoimmune diseases usually travel in packs. So you can have thyroid disease that kind of runs in the family. You can have lupus. You can have rheumatoid arthritis. You can have celiac disease, which is an intolerance to gluten. So when I'm talking to a patient, I'm trying to ascertain what could be going on. Sometimes it's a slam dunk and you know exactly what it is. Other times they'll say, does anybody else have this? Does anybody else have like Crohn's disease or lupus or rheumatoid arthritis? And when they say yes, then I think to myself, okay, we're on to something. Autoimmune diseases travel in packs. So the chance that this could be something autoimmune is very likely.
Thank you. Thank you for discussing that. And again, a question for both of you. Let's say you're managing a patient and they're doing okay. Is there something, advice you give to the patient about when maybe they need to see a doctor more urgently, like a change in symptom that is more alarming?
Yes, absolutely. I can help with to answer on this question. So in my each note is written, like come back if there is any urgent, necessity. And I'm always telling my patients, we are going through all signs of disease, treating different part of the thyroid eye disease, working on like understanding. And also, if there is a need to, do more often visits, I'm explaining why is that more important. If it is not important to have like every 2-3 months visit, then we are spreading out those visits in the best interest of the patient. But then they always, I'm making sure they understand that there are several ways that they can contact me, and then when they need to come back and when is urgent situation. And I think that, patients are very well educated. Patients understand this, and they're really, all our patients are very thankful for our approach. And then when we are understanding each other in this way. So I'm thinking that both Dr. Kachikian and I are very open to our patients and making sure that they can always approach us. Either if we are having patients on some, we will go later towards therapeutic options, but there is some therapeutic approaches that we need to do work in infusion centers. So we are making sure that our patients are also followed with a team that is in infusion center, and we are working very closely with all of them and making sure that we are available for our patients or team members on all the time.
Great, great.
The only thing I will add to that is, and this is part kind of being an advocate, which is why we both decided, we want to be part of this, and thank you for that, is a lot of times, and patients are getting more and more savvy, and there's more information out there on the TV to educate them. But a lot of times, at least for where I live, patients don't know the link between the thyroid and the eyes. So even if they are not having symptoms, you want to make sure you explain to them this could potentially be the case. So even if they don't see me, if they see their regular eye doctor or they see their optometrist, they can advocate for themselves.
Right, right. Is a change in vision a really critical sign that the condition is worsening, would you say?
So it can be, that's a great question. Changes in vision is always important sign, but then and that is good that patient is coming to our clinic. But then we need to understand when is, and then also to teach patients when is that important, where is like really important that they are running over to our clinic, and when they wait for the Monday or Tuesday and see me in the clinic. So there are like two very important distinguishing moments. If that is something, and that is always what I'm asking my patients, okay, do you have more pain or discomfort in the front part of the eye, greeting sensation? That can be very painful and disturbing. So then we understand that that is more dryness, dry eye, and those components, which are not so urgent. We can wait for that few days and then treat. So that's not like super urgent. But if there is some acute vision loss with a pain in the back part of the eye in a patient that already has proptosis, that there is a swelling, that there is, that other symptoms, that is urgent situation. And in last 5 years, I actually had two patients that literally ran over, and we did MRI and we did urgent treatment plan for them, and thankfully both of them are really good.
That's great. Great advice. And just a point I want to make before we hear from Julie and David is really, regardless of what condition somebody has, whether it's TED, a retinal disease, or something affecting the rest of their body, I think it's so important for patients to learn to advocate for themselves and find physicians like both of you who are so accessible and such great communicators and there for the patients. That isn't always an easy thing to do, but thank you both for being obviously here today, but for the work you're doing on the front lines to be there for patients when they need you. That's so important. And communication, we can't say enough about that. And so my advice to the patients is try to find your advocates, you're the people that are really going to help you on your journey. But let's transition. I'd like to introduce Julie again. Julie, it's great to have you on the webinar. And can you tell us a little bit about who you are and your diagnostic journey and kind of where you're at in your condition?
Thank you, Ben. First of all, again, thank you to the Foundation for Fighting Blindness. I appreciate this opportunity. I appreciate being here with all of you doctors and also with David, a patient as well. So, listen, I am always learning about thyroid eye disease and Graves' disease, and the doctors have just dropped some wonderful nuggets that I was sitting here taking notes because I'm always learning something new. So a little about me, as you mentioned in the bio, I am a 30-year educator, and I work for the third largest school district in the country. So you can imagine all of the pressures that come behind working for such a large school district. And have worked mainly in the role as a professional development trainer. And there's a lot of stress that comes along with that. But some of it is good stress, but some of it, can be a little challenging. And I had started noticing, I would say in 2019, 2020, I started noticing that my eyes were consistently red, they were irritated, they were swelling, they were watering, and this was a lot. And I first started attributing it to the work that I did because I constantly designed trainings and did a lot of presentations. So I thought maybe it was computer work as to why the cause of those symptoms were happening. But then again, it just started worsening. So I my primary care physician had given me a list of names of a couple of endocrinologists. I went to the endocrinologist, and like you said, when you open the door as a physician, you can look at a person and there's just certain things that and that was the case with me. So she started asking me a series of questions, and you happened to mention, both of you mentioned stress and triggers with autoimmune disease, and that's one of the questions that she asked. She asked me, have you experienced a recent loss, or has something tragic happened? And all of those questions, and I'm answering no, 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 no. Well, long story short, there was something that I realized that was a stressor, and immediately labs. I'm so used to having a lot of lab work done. And of course, the labs, it tells the story about the patient. It actually starts the story. And so from there, we started with ultrasound, we started with biopsies and all of that. And I ended up having to have a total thyroidectomy. Well, it didn't stop there. So moving forward, a couple years after that, again, symptoms coming about, and then I just had a lot of weight loss. I lost like about 20 pounds. And then again, the labs told a story, and I was diagnosed with Graves' disease. And I had never heard of Graves' disease before. And I did panic a little bit, but she assured me, listen, we're going to get through this. So a couple months after that, she said, I am going to refer you out, and I'm going to refer you out to a neuro-ophthalmologist. And so I would say maybe about 4 or 5 months, I went to the neuro-ophthalmologist and discovered that thyroid eye disease. And again, labs, I was having lab work done every 3 months, pretty much. My numbers were really off the chart. Somewhat unrelated, but a little related. We found out that I had a pituitary tumor. So that was something else and that I had to deal with. And before that, I got a treatment of oral steroids because there was a concern about acute vision loss, like as was mentioned. So went on oral steroids, didn't really work. Then I was prescribed a treatment of IV steroids. IV steroids, I did that for a course of over 12 weeks every week. We thought things kind of became a little bit better. It did not. And we kept moving forward. And finally, she put in a request for me to get a treatment of a drug that was fairly new that came out on the market. And I did those infusions over the course of 6 months. After that, there was an improvement. There was improvement with my symptoms. I started looking a little bit better. I started feeling a little bit better. And then, of course, after a year, things started slowly but surely reverting back to my original state that I was in when I first went to the physician. Then we started back with the IV steroids again, because again, there was that concern with the vision loss. By this time, I had had 3 different prescriptions for with my eyeglasses at this time because it was I couldn't see. And because I had bulging eyes, I had proptosis, it was difficult. My eyelids were pressing against the lenses of my eyeglasses. So it was very difficult for me to keep the glasses on and to see. And so, again, like I said, we did the round of steroids. And then the tables started turning. And we got to a point where things were getting better. They were getting better. And my physician said, you know what? I think we're at the point where when you first came in, you had a question about, and I'm like, how can I fix all of this? Is there a makeup? Is there something that I can do? And she said, I think we're at that point now where we can discuss surgery. And so then after that, in turn, I did have surgery. I had blepharoplasty surgery, and I had a orbital decompression and a couple of other things. And things just got a whole lot better for me. I could see. I looked like a totally different person than I did in 2020. And the pictures that you put up originally with the slides, that was me. And I'm like, oh my goodness, this is taking me down memory lane of where I started into where I am today. And it has truly helped me mentally. It has helped me emotionally. It has helped me physically, mentally, and emotionally. It was a drain on me, knowing that I'm going to work, and I was very self-conscious, and I always thought people were staring at me because of my eyes. And at one point, it was a concern if they thought I was on drugs because of my eyes and how swollen they were, the inflammation that it was, and because they were so red, that was a big concern. And because I wasn't feeling well, with the Graves' disease. So it was very stressful for me. And I did at some point, I had to get a therapist to help me navigate all of this. And it was, very, very difficult. And so the therapist and the doctor talk about multidisciplinary groups. Listen, I'm a witness to that because all of my doctors and surgeons, they work together in tandem so perfectly for me. And I know that's not always the case for everyone, but for me, I have nothing but good things to say, that they all cared about my interest and my health, and they all work together so cohesively. But where I am today, I had a doctor visit about 2 or 3 weeks ago with my neuro-ophthalmologist, and just like you said, uh, she walked in the door and she's like, uh-oh. So there are some things that we have to discuss because I do have an appointment with her in 2 weeks. So, but I'm being very positive about this, and as of right now, there is no cure. And but I am hopeful because there are a lot of resources that are out there, and it contributes to me learning about the best quality of life for me as I navigate through this journey.
All I can say is, wow, that's an incredible journey. And to see you smiling now and sharing that journey with us. Thank you. I mean, thanks for sharing that. It really indicates how challenging this condition can be. And I have more questions, but I do want to get to David. But one question I have for the doctors that kind of came up while Julie was talking. So Julie had her thyroid removed, correct? How come this is showing my ignorance about thyroid eye disease. How come the disease is still there if someone has their thyroid?
I guess I'll start with this. Because it's an autoimmune condition, the immune response is still there. So the thyroid is only part of it. So if you remove the thyroid, then the patient doesn't have hyperthyroidism. And there is some research out there that getting rid of the thyroid reduces the immune response, but it doesn't make it go away completely. And I think that's why her eye symptoms continue to progress. And the reason that eye surgery, and this is a debate in the world of endocrinology, the reason that doing a thyroidectomy or removing the thyroid is not first-line therapy is because anti-thyroid medications also work, and you can get an meaning reduction in that antigenic response a little bit faster. And some people think that surgery has more side effects. And then there's other thought, and Dr. Kostick can talk about this with, this is like a double-edged sword where you do surgery and then surgery is considered an additional stress to your body. And additional stress to your body, like Julie was saying, can exacerbate your eye disease further.
Yes, absolutely. So when we are talking about eye changes, so even after thyroidectomy or any other thyroid surgery, we still have all of those changes. And to make sure how we can the best help our patients, I like always to make sure that we are waiting. If there is a really need for surgery, then we are waiting for surgery to be done, to try to wait for stabilizations of symptoms from endocrinology side, and then we are proceeding with treatment for thyroid eye disease. In a treatment, like definitive treatment, which one of that is medications that we are currently giving in infusions. And of course, in the meantime, we are always starting immediately with the dry eye treatment and cold compresses and those other supportive treatment regardless of thyroid surgery.
Okay.
But I just would like to add one more thing, what both of us discussed, Dr. Kachikian and I. So here is a crucial moment when we all need to work together. And then, we both, endocrinologists, ophthalmologists, and patients, and even some other doctors needs to be together in this whole journey. And that is very important to know who is your first or right hand, the person that you can always call for help, that you can have as an additional advice. And I think that is like really, really, really important and crucial in those moments.
Most definitely. Most definitely. Thank you. So David, when your name first came up as a potential participant for this webinar, I was like, huh? There's a typo there, because I've known you for more than 2 decades. And obviously you've been such a great volunteer leader of the foundation. And I had no idea that you were impacted by Ted or Graves. So can you talk about your journey, which I believe is a little newer than Julie's?
Yes, indeed. My symptoms and my journey is nothing like Julie's. I'm so sorry, Julie, for what you've had to go through. And for those of listening, I'm at an airport, so if you hear somebody talking about boarding planes, you'll know. I apologize for that. During COVID, I thought I was really doing well because I was losing weight. And I thought, wow, this is really going well. And I didn't pay attention to the fact that I could, my heart rate wasn't rapid, but I could like feel it, like it boop, 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 boop. I wasn't really paying attention to it. And then, I got on the scale one day and I'd lost 20 pounds and I thought, oh, this doesn't make any sense. So I called my doctor, and he said, well, you need to see an endocrinologist. And I went to see the endocrinologist, and she, like Julie said, it starts the process of blood work and to test where your thyroid the chems are. And so for me, what's happened is over the last 3 years or so, I get the blood work done every 3 months. And interestingly, the meds that they give me, sometimes my numbers will be high, sometimes they'll be low. We keep adjusting the amount of the meds. And then, you have the opportunity of, killing part of the thyroid with an iodine solution or having the thyroid taken out or whatnot. So my symptoms at this point really are just that this has to be constantly monitored. My eyes do get I have the same bulge that she talks about. You can see the bulging on the bottom of the eye. The glasses help to protect that. But my eyes tear and itch. So she's giving me drops for that. And it's just, I monitor that on a pretty consistent basis. And I haven't yet had, the severe symptoms that Julie's had. And so, that's really been my journey to this date. And, it was interesting to me to listen to your experience, Julie, because given mine, I thought, well, this isn't so horrible. I can deal with this. But, I see now that it does evolve and it really needs to be watched. One other thing that I would say, oh, there we go. Is that finding an endocrinologist in a lot of towns is not easy, partly because they're so busy, and so you really have to work hard, and you really have to work hard to communicate with that person when you do have someone that is monitoring you, and not say, well, okay, maybe I'll only go for the blood work every 6 months, or I won't have appointments to see the doctor, so because they have to examine you sometimes. So it really is important to stay on top of your progression, even if you're not having a lot of symptoms at this point. So that's really been my experience. I'm gonna mute it here so that you guys don't have to listen.
You've come in loud and clear, so the airport noise hasn't been a problem, which is good.
Okay, good. Well, that's all.
A question related to David for the doctors. I'm just curious, and David, I'm not going to ask your age, but you were diagnosed relatively late in life, at least from my vantage point. Is that unusual? Is there a certain age range that people are typically diagnosed with TED or Graves' disease?
It can happen at any age. Women are more likely to be diagnosed than men. Older patients have worse disease. But no, it can come on at any time. Sometimes it happens in a young person, sometimes it happens later. Sometimes they've had it for a long time, and unless they go to a doctor regularly, they don't notice it. I know I'm taking your job over, Ben, and I don't mean to take your job over, but I actually had a question for David. And this is what I was saying. Like he's, in tune with his body, but he was losing weight. He was having palpitations. And I can't tell you how many people just they're like, oh, well, this is because of this, or this is because I'm on medicine for this, or it's just, your body gives you these symptoms, and oftentimes people are like, yeah, I'm tired, yeah, I'm not sleeping, but I just thought that was normal. So it happens very, very slowly. But David, you look great. I mean, and I'm not seeing you up close. So who helped you make the distinction between your eyes, even some of the subtle symptoms you're having, and your thyroid?
So my primary physician, um, when he heard that I was, losing weight and that I had the palpitations, he made the diagnosis quickly that I'd need to see an endocrinologist. And so we got in to see someone fairly quickly, who, like you said, when I forgot which doctor said, somebody walks in and they tell them a couple things, and she just we'll test it, but you've got Graves' disease. they just knew. And then sure enough, the numbers were off, and that's really what's happened. But one of the things I wanted to add was, and I said to her sort of jokingly, I said, so can I go on and off the meds if I want to lose weight? And she said, well, I did go to the emergency room the other day for a patient who did that, and they had significant heart problems. So, you can't fool around with this. This is something that has to be addressed, and I guess it can affect different parts of the body in addition to the eyes.
I like endocrine, but somebody had asked a question. Fixing the thyroid doesn't fix the eyes. Fixing the eyes doesn't fix the thyroid. So they can coexist, but they're two different diseases, which is why we are here today to try to explain to people that it is two different diseases. It used to be, it doesn't matter what you call it. I mean, the right term now is thyroid eye disease, but it is, we need to acknowledge it. We need to acknowledge the burden it takes on patients, and we need to treat them.
Great points. Great points. And you answered one of the questions that came in through the chat. And I want to take this moment to let participants know if they have questions, please send them to the chat. But a question I have for Julie, David, and really the whole panel is, what lifestyle adjustments, it sounds like stress management is really important, but what are some general lifestyle adjustments that are really universal for people with TED and or Graves' disease?
Wow. Okay. So I can tell you what I've done. And stress will happen, right? As long as we continue to live on this earth, things will happen. And there will be triggers. What I have learned is how to manage those triggers. The things that I can manage, I do. The things that I cannot manage, I have to make the decision, is it worth it for me or not? And that's exactly how I approach it. Just to share just a little bit, I mentioned a couple of weeks ago that my neuro-ophthalmologist walked in the room and she looked at me and she was like, uh-oh, what's going on? Well, unfortunately, I suffered a double loss in this past December. My mother passed away unexpectedly Thanksgiving night. My father passed away 2 weeks after her unexpectedly. So that is something that I dealt with towards the end of last year. And yes, that is extremely stressful. But throughout that, I had to constantly remind myself, do what you can, and what you can't, you don't. And, there are tools, there are things that I can do to get through this. So what I do, I was listening to a webinar not too long ago, and a gentleman had said, we know what we have, right? If you've been diagnosed and you do what you can, but it was 3 things he said that I will always remember. He said, eat the cake, buy the shoes, and take the trip. I have done that nonstop. I will eat the cake. I just ate a piece of carrot cake last night that I wasn't supposed to have, but it was doggone good. I have bought shoes that I knew I didn't need, but I wanted it. And I'm taking the trips. And I said all that to say is, after suffering the loss of the 2 most important people in my life, anything that happens after that, I make the decision. If I want to do it, I do it. If I don't want to do it, I don't. And but I try to manage the stress as best as I can. If it's too much for me, I unapologetically will walk away and I don't think twice about it. You know, that's just how I am moving in this latter part of my life. And when I say latter, the first 50 years, you know, I did what people expected. These last 50 years, I'm going to do what I want to do. And that's just the way it is, unapologetically. So that's what I do for me.
I love that attitude and advice. And somebody put in the chat, "Dear Julie, thank you for sharing your story. I applaud your resilience and your strength. You are amazing." And I agree with all those comments. So thank you.
Thank you.
Now, I don't want to detract from Eat the Cake. I have a nice big cookie back here that I'm going to partake in later this evening. But for the doctors, is there some general lifestyle or dietary guidance that you give people? Maybe you shouldn't be eating a big piece of cake every day. I don't know. Let us know what your feelings are.
So I think that there is no magic food restriction or food diet for thyroid eye disease, but I think that it's very important for all our patients have a message that they are not alone, that we are here to help them, and also to understand when we need to suggest additional help. Because especially in neuro-ophthalmology, I have different patients, not just with TED, that has vision loss, and at some moment it can be, you know, stress related, or they cannot sleep, or so many different reasons. So in those situations, we need to decide also when is the need to have additional help from some of our colleagues, either a psychologist, psychiatrist, psychotherapist. And also, I think patients group are much more important than, you know, than us. We are here to navigate many initial steps, to open the door, to put like small pathway, go left, go right, no, don't go too much left, let's go straight. But overall, the best message is coming when our patients are finding their peer that is, you know, fitting to their stories and to their experience, and they can really ask those small things. But, you know, we really need to, as a physicians, understand our patients, which I think that we are all trying to do, and also to help them in each part of their satisfaction. So it can be, you know, so there are patients that has thyroid eye disease, but they additionally would like to lose weight. Okay, let's work on that. So, but I think that cake here is not crucial at this moment. Cake is not as a part of diet. Cake is as a part of stress relief and satisfactory. And I think it's like really important to have all of that for all of us. And only if you're not, you know, understanding that you are not alone in this moment, I think that is additionally, you know, the very important information for all of us. And I'm trying always to spend time, especially during first visit with those patients, because many of patients that have thyroid eye disease, when they are coming in my office, they look like they ran like a whole marathon. You know, they saw so many doctors, they went left and right, tried to ask um, for the help, and then they are there. So let's go from there. So that is my impression. But on the other side, I'm very thankful to whole society, including our colleagues for pharmaceutical industry, where we are working as a win-win situation. We are collaborating in the best possible way to give education, to give support our patients, and to bring the newest you know, diagnosis, education, and therapy for all our patients. Thank you.
Great answer. Dr. Kachikian, do you have anything to add about diet or other lifestyle practices that you think are
So
important?
I like how Dr. Kosick is making me do the mean stuff. I jokingly tell my patients, but this is a serious thing. We know smoking can make eye disease worse. Smoking is terrible for a lot of different reasons. And I say jokingly because I know my patients feel as though I nag them. In fact, one of my patients looked at me straight in the eye and he said, Dr. K, nobody likes a quitter. I was like, okay, well, if this is the hill you're willing to die on, but smoking does make thyroid eye disease worse, right? So that's one thing that you can do from your standpoint. And Julie will tell you, I mean, it is debilitating. So anything you can do to help, ameliorate the situation is better. The other thing is one of the treatments for thyroid eye disease, radioactive iodine, it can also make thyroid eye disease worse. So if you're already suffering from thyroid eye disease and now you're educating yourself about what the symptoms are, even if you don't have that like bulging of your eyes, then maybe you need to tell your doctor that. So when she or he is trying to come up with a treatment regimen for you, maybe they don't go down that route. Those are the two things I can think about.
Okay, good points. I want to take a question that came in through the chat. It sort of relates to my question about the thyroid removal. But this person asks, is it possible to have TED with the normal lab study of the thyroid?
Dr. Kosick, you want to take that? You want me to take that?
Maybe you can start if you like, and then I will add more some of cases that I had.
So the majority of cases of patients who have thyroid eye disease are seen in patients who are hyperthyroid, over 85% of them. Having said that, the more we're finding out about the disease, we know that autoimmune thyroid, so if it's something like Hashimoto's, which is one of the other most common causes of having an underactive thyroid, can also have a small subset of patients who have thyroid eye disease. And then there are patients who are completely euthyroid, meaning their thyroid function is normal, and they can have thyroid eye disease. Usually, if you check their labs, you can see that their antibodies are positive, meaning those are the things that attack the thyroid or the muscles in the back of the eye. And this is where the family history is really important, where you really want to try to get, some sort of idea of, is there autoimmune disease in the family? And this is where Dr. Kosick will tell you imaging may be really helpful.
Yes, I do agree. And I would add that just recently I had a patient that we did all possible testing with our endocrinology team, and he came back negative for any disease, but he had such a like severe double vision that we couldn't correct. When you have a patient that has double vision, that is binocular, which means with both eyes open, that you cannot correct easy. So there is something active is going on. And then because it's like vertical double vision, my first diagnosis was like, okay, differential diagnosis was like, this is some problem with thyroid. Patient came back with all laboratory results normal, but still like such a strong, like such a big double vision. And then we are like, I suggested to go and do MRI. And then when we did MRI of the brain and orbits, you can see that muscle that is down here, that is pulling our eyes down. We are calling that rectus muscle, inferior rectus muscle. It's such a big muscle. And that is so typical for thyroid eye disease, but this patient had all negative results. So we still decided to go and proceed and treat him with thyroid eye, like thyroid eye disease management. And he is currently in a treatment with infusions.
Interesting.
And I think that
Oh, sorry.
I'm so sorry. Just to add, I think that we are, I'm always telling him in medicine, one and one are never two. So we have always, this some percentage of patients that can have, normal values, but clinically that they are having changes. And we are seeing, many additionally in another diseases, which is not a topic at this moment, but we are seeing that. And I think that is crucial, again, to work together and to decide what is the best interest for our patient.
The only thing I was going to add is something that came up in the chat is what thyroid levels do you need to get to make the diagnosis? And the diagnosis of thyroid eye disease is a clinical diagnosis. So sometimes we use lab tests to help augment the diagnosis, but it's a clinical exam, it's a clinical diagnosis. So you don't need to have any thyroid labs to make the diagnosis.
Interesting. It's a very challenging thing to diagnose, it sounds like sometimes. On some occasions, it's obvious, perhaps with the bulging eyes, etc., but other times not so obvious. Both of you have brought up MRIs. And why do you order MRIs? What are you looking for when you order an MRI with somebody who has the condition or you think might have it?
Yeah, so first of all, I can answer to this question because I think that the MRI is like almost routine diagnostic method in neuro-ophthalmology practice. We are just joking about that because we have so many patients with this type of disease that we really need to go and order MRIs. So particularly in patients with thyroid eye disease, especially if there is asymmetric changes. So we first, if there is a patient with symmetrical changes, we have all information from endocrinologist, from primary care physician. Patient is for a long time has diagnosis. Then it's pretty clear how, we understand this disease. But then if there is a lot of bulging of the eyes, especially if there is pain, and additionally asymmetric changes in the eyes, then we need to do MRI because we always need to think outside of box. So we always need to think, is this really thyroid eye disease or there is something else? Something else, we're always thinking, is there any tumor or is there any malformation? Is there, any other change that we need to first address and then to make a further decision about treating thyroid eye disease if there is real thyroid eye disease. So the other reason why I like MRI to do, it's like at the beginning of the treatment, especially for some patients. I'm not doing that routinely, but for all asymmetric cases, yes, I'm doing that. But for some patients, because they have such a big change in such a short period of time, then you can see like all different changes. So we are also trying to understand clinically, but also from research standpoint, is there some early biomarkers or some changes that we can better understand all of those changes? And then even not only MRI, in neuro-ophthalmology, we are always doing visual field test. So visual field test is how wide we can see with one and another eye and how we can, so that is subjective test, but also we can understand different problems if there is any. And then we can, with additional OCT, ocular coherence tomography, that is some special imaging that we are using. I'm calling that like a small MRI specifically for eyes, just in everyday practice to make it easier for our patients. So there we can see the earliest sign on compression. Is there anything that muscles that are behind our eyes are squeezing or pressing on the optic nerve, which is like urgent situation? And that is the moment that I mentioned before when we really need to treat immediately and to prevent blindness.
Thanks. Great answer. And we're getting more questions in the chat, but one thing I want to make sure we cover are clinical trials and research. And that's a question we often get in the retinal disease world. But I guess I'll ask it in two parts. How do people learn about the research that's underway for TED? And what do you think people should know before embarking on perhaps a clinical trial? Dr. Kachikian, you want to start or? well, whomever, I don't.
I can, yeah, either ways.
No, I think Dr. Kostick, I mean, she's being very humble. She's a super duper eye specialist, I think, and she's at one of the best places in the world. So I think she can take this question.
Yeah, thank you so much for all nice words. I'm thinking that when we are talking about clinical research, because this is very hot topic in ophthalmology, but also in a multidisciplinary approach, there are more and more. So we have one of our golden sponsor actually for this meeting that I think I can disclose the name, which is Amgen, and we are very thankful for all education that Amgen team is doing and working on all different levels, including doctors, all different specialists, and patients, and advocating for patients. So there are like multiple studies that Amgen is doing, but there are several other companies that are coming now with different approaches, and each goal of each company is to try to find what is the most precise. Those are all new type of medication that I think we don't need to go like so deeply into that right now, but those are all new type of medication that we are trying to find the most precise dose for the shortest period of time, and that is less invasive in administration. So instead of giving this or that approach, if we can go like towards subcutaneous injection, or we can go into oral forms, or we can do patch in the future. So it can be, so we are always discussing on all of those different approaches, and also trying to understand what is the smallest possible dose. And all of these, trials and everything that is going on in our collaboration with pharmaceutical industry is really hard work for many years, on many different levels. But if you are a patient that is looking for some trial, you can always ask your doctor, or you can look into closest, there is on a website, there is clinicaltrial.gov, and then you can enter their thyroid eye diseases or thyroid eye disease, and look what are different studies that are going on. And then those different studies have inclusion and exclusion criteria. So the best way is, yes, you can go and look for all of these, but the best way is to go and talk or call the clinic that you are thinking, or private clinic, private office, so that you are thinking it can be good fit for you. Additionally, there is within companies, there is also a department that is, of course, collaborating with all different doctors and can navigate you towards different studies. And once when you find what is find a doctor that you can participate into study, then there is additional procedure, but overall it's very important to understand, if I'm a patient, okay, what are opportunities, what is the best study for me, and how long is that study, am I ready for that study or not, and what are our expectations from there. So
Right. I think it's important for people to understand that often a clinical trial is a pretty big commitment of time,
absolutely.
especially if you have to travel. And it is still research. We're learning in humans how a particular therapy is working. So we need people for clinical research, most definitely, whatever the condition. But there are risks and there are commitments. And I think that's important for people to understand. I want to get back to some of the questions in the chat. And one person asks about evidence for natural treatments. And I'm not going to get into specific ones, but are there any more natural, I don't know, vitamins, herbs, anything like that, that either of you, Dr. Costa or Kachikian, I think may be helpful for people with TED?
There's been some trials done that show that selenium, which can be found in the Brazil nut, at doses can disease, and in those patients, it's believed that you could be on it for about 6 months. So if it's something that they can try, that's one option for them.
Okay. Thank you. Another question. This is very specific, but maybe other people have the same question. This person has Graves and TED. He or she says, my endocrinologist has suggested possibly getting a thyroid artery embolization. Do you have any thoughts on that? Or is that something somebody really needs to talk about with their own doc?
I don't know much about that topic. I think it's something that you need to talk about. I haven't heard a lot of research about it. Dr. Kostic, have you?
No, but I think that the best way is to really understand, because as we discussed, Dr. Kachikian and I, even if we are talking about thyroid eye disease or any, and also different thyroid disease, so each patient is has its own story. So with those information that you shared with us, I think we don't have enough information to make a final suggestion. Why is that the best approach for you? Is this really the best approach for you? So if I'm if I'm a patient, I would like to know pros and cons for this treatment option and why I'm not a candidate for something else. Or maybe this is the best for me according to my doctor because of that and that and that. So I would schedule, additional meeting with my endocrinologist and go from there. But I didn't have any like big experience with this, or I didn't hear from my patients.
Okay, thanks again for sharing your thoughts on that. Another fairly specific question. Could medications like Cytomel, which may cause high free T3 labs in treating Hashimoto's hypothyroiditis, be a concern for thyroid eye disease? I hope I said all the words in there correctly.
Again, treating the thyroid doesn't affect the eyes. Treating the eyes doesn't affect the thyroid. You need to do each independently. There's only been studies that show that if a patient is significantly hypothyroid or has a period of hypothyroidism, that can exacerbate eye symptoms slightly. But no, specific medicine shouldn't be causing that.
Okay. Thanks for clarifying that. Another question. This person has thyroid eye disease. They've had steroid injections and radiation treatment with no effect on their double vision. Will Tepezza or perhaps something else help with double vision?
Yeah, I can answer on this question. This is a great
Okay.
question. And we need here to understand double vision. Okay, so which is one huge topic. But in this particular situation, I think that it's pretty obvious that this double vision is coming because of thyroid eye disease. So then we need to understand what is the mechanism in this situation of Tepezza as a medication. And Tepezza is working in the area behind our eyes. It's working dominantly of the fat tissue, but also working on the muscles. So if we are thinking in that way, yes, Tepezza can help decreasing or neutralizing double vision, but we need to understand what is our starting point, what is the type of double vision and all other characteristics of double vision to be able to answer better on this question. But overall, yes, Tepezza can have, and other medications in this particular situation, Tepezza was the question, and that is the medication that I have really great experience. on double vision, it's very helpful. The amount of, like resolved double vision, depending where is the starting point, and also how many years patients has double vision.
Great, great. And sort of a follow-up to that, Dr. Kostick, what ways do you typically help people with their eyes and vision? I guess more so vision.
Vision, thanks so much for that question. It's a great question. So I'm always trying, if you're talking about thyroid eye disease or any other patient that is coming in my office, to understand what is the main thing or what is the main symptom that is bothering them. Because we can have patient with thyroid eye disease and patient can have 5, 6, 10 symptoms. But usually there is 1 or 2 symptoms or things, that are bothering them. So, the thing, why I'm saying the thing, it can be like, I'm not going anymore on parties. I cannot look at myself in a mirror, So that is how, what our patients are telling us. Then another patient is like, oh, I have this double vision. So double vision is very often the earliest sign for, in thyroid eye disease, and especially we have vertical double vision in this disease that is much more, it's making a bigger problem comparing with horizontal vision that we are seeing in different other diseases. So that is what I'm thinking in the shortest way, but I can talk about that like day and night and different approaches.
I'm curious how you go about treating double vision.
Okay.
Is
So,
that you do with glasses? Can you?
yeah, I can explain.
Okay.
I'm sorry that I'm not in my office today, but there is like some specific tools. And the thing is that first, I always talking with my patient in the way like, okay, to understand, is this double vision is monocular or binocular double vision? And then from there, we are going and understanding what is the amount of eye misalignment. We are measuring that in prism diopters. And then from there, we can go and try to give glasses that are specific glasses, which we are first going with. There is a specific, like a sticker prism that is we are sticking on a current glasses. And I like to try that first because with thyroid eye disease, we very often have we need that trial time frame because many patients are not stable with double vision. And then, because many of them, I think that in the way how those are like 2 different diseases, but they are also together in the way that if hormonal level is not, good, we still can have difference in double vision. And then if patient is happy after a few weeks or 1 month, then we can, I'm giving option patient, we can go and put prism in the glasses, or we can go and decide about those like Fresnel prism. Additionally, if we cannot go and if we are happy with those prism glasses over time, but angle that we have of eye misalignment is big enough for surgery or pretty or very big, we are recommending surgery. For that part, we are recommending our colleagues that are proceeding with the surgery. We have a great team that is working at Bascom Palmer Eye Institute, and they are proceeding with different measurements. I'm doing my baseline measurements, but then they are taking over and proceeding from there. We need to have at least 2 to 3 stable measurements with them in a visit, and then to decide about surgery. In the meantime, there is also our colleagues from oculoplastic, ophthalmologists that are doing if there is a need for decompressive surgery, but I think that number of this type of surgery is much smaller in last few years, thankfully to Tepezza, that was the first medication on a market, and also thankfully to others that are coming more and more.
Great. So there are multiple options for treating those visual issues. We're getting close to 1:30 here on the East Coast, and I want to ask Julie and David if you've been standing by patiently while we're talking about a lot of medical things. Are there any final thoughts or comments that come to mind after sitting through all the medical discussion that you want to make before I conclude here? Julie?
Well, again, this has been very educational for me. I have a lot of notes that I'm going to review afterwards, but it's assuring to hear the different treatments that both doctors have done and what they continue to do. So it's very, very comforting and assuring to know that I'm in the right place, in the right space, with my, with my journey. But most importantly, even the questions that were coming in, for everyone to just get clarity about thyroid eye disease and about Graves' disease, continue to ask those questions. I want to say to the participants that are on, ask those questions, get clarity. I still ask questions. I still take notes because this is a life journey here for me. So whatever I am learning and whatever I need to know to help me to have a better quality of life, I'm definitely, there, and I'm present for it to hear what the experts are saying. And along with hearing what the experts are saying, just know for you, it can be challenging. We have heard consistently over the course of our time together that you are not alone. And please remember that you are not alone. There are people that are out there. There are organizations that are out there to help you through your journey. And it can be challenging and confusing, but just know there is help that's out there. No one person has the magic sauce, but guess what? There are a lot of ingredients that go in that sauce. So just be very persistent, advocate for yourself, advocate for your loved one, whoever is experiencing this, and just continue and try to present your best self through your journey.
Extremely well put. I couldn't have said it better myself. David?
You really want me to go after that? Look, I think Julie put it really very well, and hope everybody will take that to heart, especially for those who have milder symptoms, not to take it for granted, because it evolves, and we heard that diseases like Graves' disease will have effects as you get older. And incidentally, for the record, I'm 64. I got it when I'm 61, so just you don't have to worry about that, Ben. You can tell anybody when it affects people, but it was a good question. So, at the foundation, we're there to help you. If you can't find assistance anywhere around the country, reach out to Ben, and we will make sure that we direct you as best that we can. And we're happy to be part of the solution, and certainly in education, people with thyroid eye disease, including me.
Very well put. Thanks. Yes, we are very willing to try to help you find the right resources. And I'm going to talk about that in a second, but I want to extend my appreciation and just a big thank you to Doctors Kachikian and Kostic for just so much information and handling so many great questions from me and our audience. It's really, really been enlightening. So thank you both. And let me bring up my last slide here. Hold on. I want to again, as we wrap up here, thank the many numerous national partners listed on this slide that have made this webinar and other resources possible. Thank you to all. And if you're interested in additional resources, you can get involved in our Vision Walk, which is a great community for meeting other people, not only in the retinal disease space, but in the TED space as well. You can do that by going to fightingblindness.org/Vision Walk. And there is an organization in the TED community that's aptly called the TED Community Organization. And they have a conference called Connected, which is being held November 10th through 15th. And you can learn about that or register for that at tedcommunity.org/connected. Again, that's tedcommunity.org/connected. And then finally, the foundation has launched a new mental health resource page on our website to get connected to a mental health therapist, counselor. We heard today how important that can be in terms of managing stress and the emotional challenges of TED and other conditions. So again, you can take advantage of that. Our mental health resources are available at fightingblindness.org/mental-health. Again, that's fightingblindness.org/mental-health. So thank you again to all of our audience, the participants. Great to have you. And thanks again to our panelists for taking time out of your Saturday to share your stories, your experience and knowledge. It's been a really great experience.
Ben, if I can share, please, if it's okay.
Of
The
course.
TED Connected conference that's coming up, I am a part of TED Build, the TED community and a TED Builder, and we're looking forward to doing that session the entire week, and I will be leading that Wednesday night session with some fabulous people talking about the quality of life of living with TED.
Well, I'm sure that will be a great session. So thank you for saying that, Julie.
Thank you.
Okay, well, I will officially conclude the webinar now. Thanks again to everyone, our panelists. It's been a really great hour and a half. Thank you and enjoy the rest of your Saturday.